Good morning, ladies and gentlemen.
Good morning, Batch Procordia.
Good morning, doctors.
Good morning, everyone. We are the senior clerks from the CIM CMSS Departments of Preventive and Community Medicine.
We welcome you all in this online clinical sociological case presentation entitled Bugsay, a webinar on persons with disabilities in the time of COVID-19.
Before we formally begin, let us ask for God's grace through prayer.
Father, thank you for the gift of a new day. Thank you for the opportunity to begin again. We praise you for this day and your purpose for it. Recalibrate our intentions and refocus our hearts as we sit in your presence. We humbly ask for your forgiveness for our shortcomings. We come before you today in appreciation for all that you have done for us. As the events of the day continue to unroll, we ask for your wonderful grace and for your clarity. We know you are with us and for us as we gather together in this morning's meeting. Please bless all those present, each mind and heart that feels the presence of this meeting, as well as the lives of those we will encounter afterward. Only you truly know what we are setting out to accomplish today. Take what we have prepared and multiply our efforts as only you can. Blanket us with your peace today. Keep us physically safe and guard our feet that may we never fall into bad circumstances. Keep love at the forefront of our minds and the guiding light for all we set out to accomplish and celebrate. In Jesus' name, Amen.
Hello, this is Golda.
And I am Carla. We will be your moderators for this morning's webinar. For any questions regarding our topic, you may leave a comment in the comment section below.
We will make sure to answer your questions in the open forum at the end of our presentation.
We would like to thank you for joining us this morning.
Once again, we welcome you all and good morning.
Ako si Melvin Baruman, taga Sungabi, Patnaan, Mandawi. Usa ko ka PWD.
Globally, over 1 billion people, or approximately 15% of the world's population, have some form of disability. In the Philippines, according to the 2010 Census of Population and Housing, 1.443 million Filipinos have a disability. Region 4A was recorded to have the highest number of PWDs among the 17 regions. 80% of the world's PWDs live in low-income countries wherein majority cannot access basic services. With the COVID-19 pandemic, the impact of inaccessible and inadequate healthcare services on PWDs were magnified.
This is the story of Sir Melvin Baroman. Last October 19, 2013, at 6 a.m. in the morning, Melvin Baroman, a private company driver, was preparing to go home from his night shift duty. Sir Melvin was not drunk nor noted he was sleepy, but these unfortunate events occurred. Sir Melvin was brought to the nearest hospital where his condition was stabilized. He complained of severe pain all over his body, temporary hearing loss of both ears, and confusion. Sir Melvin needed surgery, but due to financial constraints, Sir Melvin was brought to a public hospital and awaited his surgery. Sir Melvin had sustained a spinal cord injury from the level of T3 and down. Despite the best efforts of the surgical team, Sir Melvin was still paralyzed from the level of his nipple down to both of his lower extremities. Sir Melvin was given intravenous pain medications to alleviate his pain during his hospital stay. Sir Melvin stayed in the hospital for 40 days and was discharged, still paralyzed on November 28, 2013. Take-home medications include an unrecalled oral painkiller, of which he took with good compliance. He was also advised to have physical therapy, which he did not comply due to financial reasons. Due to his spinal cord injury, he's been a paraplegic ever since. It was only in August 2019 that he was seen by the senior clerks in their community medicine rotation.
The assessment of a patient presenting with a disability requires a holistic process. It entails a multidimensional approach to assess the physical, functional, psychological, and social aspects of a PWD's life. The World Health Organization has endorsed the International Classification of Functioning, Disability and Health, or otherwise known as the ICF, to be the standard framework for describing disability and function of a patient. This model describes the interactive effects of the biological, environmental, and personal factors to the patient's levels of functioning and disability. The ICF is based on 3 levels of functioning, which are body functions and structure, activity, and participation. These 3 functions have parallel levels of disability. Body functions and structure correlates with impairments. Activity, on the other hand, correlates with the activity limitations. Lastly, participation correlates with participation restrictions. In assessing impairments, we evaluate the body functions and structure based on the level of impairment to their quality of life over the last 30 days. Here, we assess for mental functions, sensory functions and pain, voice and speech function, gastrointestinal, metabolic, and endocrine functions, genitourinary and reproductive functions, neuromusculoskeletal and movement-related functions, and lastly, functions of the skin and related structures. For activity limitations, we evaluate activity based on the capacity in executing tasks with or without assistance over the last 30 days. In here, we assess for learning and applying knowledge, general tasks and demands, communication, mobility, and self-care. For participation restrictions, we evaluate participation based on the level of difficulty in life situations over the last 30 days. Here, we assess for domestic life, such as shopping and cooking, interpersonal interactions and relationships, major life areas, and community, social, and civic life. We also evaluate the impact of environmental factors in people's function in order to identify barriers. Here, we assess for product and technology, natural environment and human-made changes such as climate, support and relationships, attitudes, and lastly, services, systems, and policies. With the ICF, any component, domain or environmental or social factor that causes limitation or disadvantage to the function of a patient are identified. These factors are utilized in the planning of necessary interventions and preventive measures in order to improve the PWD's quality of life.
In the period of 6 years, Sir Melvin did not have regular rehab therapy. Because of this, he did not significantly improve in terms of mobility and functionality. He developed several complications brought about by his current condition. He had recurrent pressure ulcers, generalized atrophy of his muscles, loss of sexual function, loss of bowel and bladder control, and knee contractures.
For this patient, we recommend supposed to be during the after the patient was diagnosed with spinal cord injury, early rehab should be started so that we don't end up with complications like contractures, atrophy. Diagnosing the patient with SCI, we should have started the patient on rehab and already given the family home exercise program in order for these complications not to happen. So here we emphasize the importance of early referral to rehab. No? But in this case, since we receive already the patient with contractures already, so first we determine if that contracture is still correctable or not. No? If it is only a soft tissue contracture, then perhaps we can still treat this with physiotherapy, use of therapeutic modalities to soften the tissue like your therapeutic ultrasound, no? And we can do serial splinting in order to improve the contractures. But if, for example, this is already a bony contracture, like there is no available joint space between the knee joints already, so that is already a surgical condition, and this warrants referral to the orthopedics. For the bed sore, bed sore treatment requires nutritional management, as well as proper cushioning. So we recommend a proper seating device, proper cushioning, so wheelchair, as well as proper relief cushions bed of the patient, so that it reduces the pressure and the shear stress sacral area where your patient have the bed sore. No? As well as we also recommend the proper dressing of the wound. No? So for some patients, we can do, for grade 2 or grade 3 ulcers, we can do wet to dry dressing, no? Or we can apply certain ointment like your Mibo ointment. But if it is already a grade 4 type of bed sore, this already requires referral to the surgery department, no? For possible debridement.
For Baroman's case, he was referred to us by a doctor in Pakdaan. And then what we did was, first we visited his home, and then we did our evaluation, and then we worked also together with Sir to come up with goals that would help him function more independently. We based our interventions on what we have gathered during the evaluation. So specifically, when we evaluated Sir Baroman, he had weakness on his lower extremity, and his upper extremity were not that yet very functional. So we did our best to come up with a goal that would enable Sir Baroman to participate with his valued occupations such as leisure activities while targeting those affected client factors. So for how many weeks? We visited Sir Baroman's house. We did OT sessions, and after a few months, we noticed improvements with his upper extremity strength and dexterity.
We based our goals for the assessment and the evaluation of Sir Melvin Baroman. We wanted Sir Baroman to sit on a wheelchair and then perform other activities, since he has a good upper extremity strength, and the problem that we saw in him was the weakness in the lower extremity. So perhaps we can still help him if he can transfer to a wheelchair.
It was never easy for the Baroman family, but Sir Melvin continued with his therapy. Due to financial problems, his wife worked abroad and Sir Melvin is left with the care of his son and mother.
May buwan may bali ang spinal cord. Hindi na siyang kaparo. May sa doktor. Doon ka sa una. Laro na yung tatawad. Larang ko pero may tapad niya. Nasa ganahan ba ito tapang tampol exercise. Nag-isod ko may papalit. Paano ito? Walang bali. Wala ito. Tapos po ko lang balik sa dito. Kapoy balik. Hindi consistent ang pagkukulang. Nakarang kami na ako sa pila para sa nakilikan. Tuan ka lang. Kaya nga na mag-concert artist. Alam, makalong. Sa tawag scholarship. Salamat kay akong kaumaman sa support lagi ako sa papa wala siya biyati. Pasalamat sa Diyos sa papa kaya siya tambag na ako.
Pagawan, kulupaan, kana wako pasabot. Sa una, sa digli ko makadawat, may anak siya, pero sa kadugay na dawat naman. Anak siya, mas maipanoon niya. Kung nag-iingon sa pari dito sa kana Vicente Soto nga mas maipa ingon anak kay makita nimo ma-istorya nimo kaysa nawa siya takilit niya pag ayang then pag trapo niya pag inla siya mga hugaw man ako diha nalapas yung mga lupangan sa konsumisan so itong gabi malabag kuan kay kuan ako ba nga sa iyang nahitabo karon basin pagpag sa Ginoo sa sir naghimaw sa iyang kuan iyang tumog ay ang ginoorom ginahibaw na akong tanan di sir gi akong saligan salir ko niya wa man ko nagplano na ako maglubong sa akong anak ang akong gusto ako may lubong sa akong anak dili kay ako maglubong ano pa yung sa dili man muna akong plano sa Ginoo muro din siya kaya siya plano naman iyan na lang ginagsapakan katurang kay sunog doon tayo ba kung na ito kay laki po saon ako pag-alisa nga mga tao tanan panangit anong aribi ang sunog dito saon na ako kaya sa Israel kung ano na ko sila ka na scout ngayon camping hindi ako na dila ako kung ano na nakatulog din na makakabas nila. Hindi lang yun na magkakawa sa paglaong. Iyang yatan. Na matibigyan ako ibawas niya kasalbaran.
Due to the COVID-19 pandemic, Wells College Department of Physical and Occupational Therapy created teletherapy.
This time of pandemic, our patients can still continue by availing of alternative services such as teletherapy.
The advantages of teletherapy is that we get to continue providing the care of our patients in the safety and the comfort of their homes, as well as the family and the family members are more involved in the care of the patient. On the disadvantage side, there is this connectivity of the internet. So if the net is not that stable, so there is a problem in our session. So the instructions might not be clearly heard on the other side. So that depends also.
Work in rehab, it's both the patient and the family. You know, the motivation to go back to society, mo na siya ibutang sa iyang hunahuna. Ikaduha, the physio, dili siguro face-to-face nga close, but the physio can still do teletherapy. Okay, what is the new environment? How does it look like? What are the things that need to be modified? Mo ni siya. Okay, so there needs to be advice also from the therapist. But thirdly is that the focus on functional activities. What teletherapy can do is shift a little bit, not really focusing so much on exercises and ES and all these things, but how can you help both the family and the patient to have a new life? How is this being done? Make the patient responsible for his own rehab. Involve the family, so that the therapeutic activities of the patient will not stop. There is still continued therapy in the home. And I believe that therapy or any form of therapy, whether it be given by an expert, by a professional, or by a trained member of the family, is talk therapy. It will still bring effects. It will still bring progress. Involve the family. Disadvantage: there is no personal touch, and then you cannot see the whole picture, ba? You know, if I want you to see, okay, what does your couch look like? In the case of the patient, what does your bed look like? When you're teaching transfers, how can you teach transfers? You know? And again, that's where the role of the family in this time of pandemic has even become more important. Okay, sa teletherapy, given the limitations, you can teach man your kuan. Okay, bring your kuan to the how does your bed look like? Talking about bed transfers, not bed teaching. How does your bed look like? Okay, so you do this and this and this and this. But still, lahig yun. But, you know, mo na siya limitation yun. Karon nga mga panahon na.
Hello! Let's discuss the programs for persons with disabilities in the Philippines. Persons with disabilities include those who have long-term physical, mental, intellectual, or sensory impairments, which in interaction with various barriers may hinder their full and effective participation in society on an equal basis with others. The mandate of the DOH to come up with a national health program for PWD was based on Republic Act No. 7277, an act providing for the rehabilitation and self-reliance of disabled persons and their integration into the mainstream of society and for other purposes, or otherwise known as the Magna Carta for Disabled Persons, and the implementing rules and regulations of the RA 7277, amended by Republic Act No. 9442. This document stipulated that the DOH is required to institute a national health program for PWDs, establish medical rehabilitation centers in provincial hospitals, and adopt an integrated and comprehensive program to the health development of PWD, which shall make essential health services available to them at an affordable cost. Administrative Order No. 2006-0003 is also issued by the DOH to provide the strategic framework and operational guidelines for the implementation of health programs for PWDs. The Comprehensive Program for Persons with Disabilities under the DSWD aims to promote services to all types of PWDs 0 to 59 years of age and are members of the self-help groups of PWDs. The program focuses on areas of disability prevention, rehabilitation, and equalization of opportunities. Moreover, it is intended to enhance the capacity of the PWDs to attain a more meaningful, productive, and satisfying way of life, and ultimately become self-reliant, productive, and contributing members of the society. The Medical Assistance Program of PCSO supports confinement, dialysis, cancer treatment, surgical supplies, implant, laboratory or diagnostic procedures, devices, non- and minimally invasive procedures, transplant procedures, cardiac procedures, and most importantly, rehabilitative therapy that could benefit our PWDs. The Cebu City government specifically support Cebuano PWDs by giving financial assistance or cash aid. Last August 2020, an amount of 3,000 pesos was given to PWDs as a cash assistance for the month of April to June 2020. Cash aid was also given to returning locally stranded PWDs due to the pandemic the moment they got back into Cebu. Proposals have also been made to further support our PWDs. These include enhancing the rights and privileges of persons with disabilities within Cebu City, and a proposal for a PDAO or a Persons with Disability Affairs Office. Aside from the national and local PWD programs, NGOs and other support groups have also been able to support PWDs through their organizational programs. Some support groups from Cebu include the Atlas Mining Community Handicapped NPC Incorporated, Cebu Braille Center Incorporated, Hands of Mercy, Help for Persons with Disabilities in the Philippines, Northfield Foundation Incorporated, and the PWDs Advocating for Rights and Empowerment.
Ako dahil si Joseph Mantok, ako ang Federation President. Nga mo lang usag tumong og tuyo ani nga na-organize aron hiusa ang ato ang mga persons with disability dinhi sa Dakmayan sa Mandawi una ma-address ang mga gikinahanglan unya maprotektahan, ma-promote ang mga rights and privileges sa mga persons with disabilities dis Mandawi. Salamat nga naay Persons with Disability Affairs Office kani nga wala kami nagsira, wala kami nag-close, nag-skeletal force lang mi during sa pandemic to address sa mga problema sa ato ang mga persons with disability. This office facilitated the distribution of assistive devices such as mga crutches, mga wheelchair para sa ilahang mobility. Ato ang gitabangan po ato ang mga membro nga mahatagan og mga medical o financial assistance para ma-address ang ilahang mga kinahanglanong medical. Ang atong opisina gyud ang facilitate nga mahatod gyud sa ilahang balay. Mahatod gyud sa ilahang balay ang mga assistance to address sa problem sa mga kaigsuonan nato nga nagugtangan trabaho, nagugtangan negosyo, kanang nagugtangan og mga puhunan. Nahatagan sila sa DSWD Region 7 through Livelihood Assistance Grant tag 10,000. Naatay yearly financial assistance every member sa registered sa PWD Dakmayan sa Mandawi na 5,000 nga assistance ihatag. Nahatag atong pagmayo. Actually during the pandemic nakitap ta sa Chuchi Foundation nga nakahatag pod sa ato ang food packs no mga panginahanglanon sa ato ang mga persons with disability. Resources for the blind hatag pod sa ato ang mga blind nga mga membro. Rafi na ay opisina sa ato ang congressman Ramon Avitis Foundation Security nihatag sila og mga food packs. City government sa Mandawi, ang mga barangay nga DSWD Region 7, ang City Social Welfare sa Dakmayan sa Mandawi ug ang Mandawi City LGU mismo no ni tabang gyud sa atoa inato gyud gi promote gi advocate nga inclusive gyud ang paghatag sa within sa naay mga hinabang appeal gyud ang mga persons with disability in order to avail sa medical assistance, financial assistance nanan siya mo nagod siya medical abstract, medical certificate, unya hospital bill kung if any or mga resita, no? Mga prescription sa tambal, unya kanang certificate of indigency sa barangay.
Naan Person with Disability Association nga as of now na 300 ka PWD different disability. Barangay Paknaan na siya ang 300 and then amo ang budget if nami mga activity is tagaan mi sa barangay og 1% budget gikan sa IRA sa barangay intended for programs and activities. So every year nagid may activity. So ang mission vision sa among grupo is kung sa among ikatabang ngadto sa among kaubang PWD magkinabangay mi Then tabangan og agap para makuha kung sa ilang panginahanglanon.
I started the foundation in the year 2000, and then we were doing volunteer work in Misamis Occidental, distributing wheelchairs, treating patients, all volunteers. And then in 2004, we moved to Dumaguete City. And then we had a project, a children's rehabilitation project, which went on from 2004 until 2013. So I'm doing mostly trainings for the BHW. So in a way, I am starting to establish a community-based rehabilitation program in its very essence ba. No other people, no rehab workers involved, just me and itong mga government grassroots workers.
That's what community-based should mean. Empowering the people to take responsibility for their care.
Hey there! In this part of the video, I will show you how to apply for a PWD card. First, what is a PWD card? So this is the standard identification card of persons with disabilities or PWDs in the Philippines. This card can be used to avail PWD benefits as mandated by the law. And this ID or card is valid for 3 years and free of charge when issued for the first time. And if lost, damaged, or had expired, you can renew your ID with just a minimal fee. Who can apply for the PWD card? The National Council on Disability Affairs listed down acceptable disabilities, and these are physical and orthopedic disability, visual impairment, hearing impairment, speech impairment, intellectual disability, and psychosocial disability. Now let's proceed with the complete requirements. First, you will be needing a valid government ID and barangay clearance or certificate of indigency. Second, an accomplished Philippine registry form for the person with disability, and you may get this form at your local government offices, National Council on Disability Affairs, DOH, and DSWD. You may also download a file or register online at the DOH's Philippine Registry for Persons with Disability. Third, provide a medical certificate or a clinical abstract from a physician, which should include the doctor's name, signature, and license number. Fourth, bring 2 pieces of 2x2 ID picture for the application form and another 2 pieces 1x1 ID picture for the medicine booklet and the ID itself. Once you receive your card, it is important to be acquainted with the benefits that come with it. Generally, a PWD ID holder is entitled to a 20% discount and VAT exemption when purchasing goods. Let's break down the privileges. A 20% discount is applied when purchasing medicines in all drugstores, medical and dental services, including laboratory and diagnostic fees in all government facilities, and professional fees in all private hospitals and medical facilities. The 20% discount is also applicable in hotels and similar lodging establishments, restos, recreation centers, theaters, cinemas, concert halls, circuses, carnivals, and other similar places of culture, leisure, and amusements. The discount can also be applied on domestic air and sea travel, public railways and bus fare, skyways and expressway stall fees. A 5% discount is also applicable when purchasing basic necessities such as rice and poultry products, prime commodities like fresh fruits, and processed or canned goods. But note, purchasing of basic necessities and prime commodities should not exceed 1,300 a week to avail of the 5% discount. There are also other benefits, and these include express lanes in all commercial and government establishments, accessible biometrics registration and voting precincts, designated PWD-friendly public attorney, protection against verbal and nonverbal ridicule and vilification, 15,000 worth of benefits to PhilHealth members and dependents in need of a lower limb prosthesis, establishment of a Persons with Disability Affairs Office in every province, city, and municipality. And lastly, an accessible website for all government offices. So, if you know any person with disability who still doesn't have the PWD card or ID, now you can inform them on how to get one.
The only way that you can sustain the programs that you are implementing is to work with government. There is no other way to do it. We have to work with government because they have the institution and then they have the funding. So that is why after so many years of working on our own with the NGO, I realized that, if someone can just lobby with government has to have programs for PWDs. That's the only way this sector can be served. And the only way their needs can be answered or responded to.
Mga persons with disability nga wala pa nagpamimbro na mga PWD nga nagtago-tago diha sa suok mo nga mauwaw nga ipakita ang ilahang mga kahimtang tungkol sa tanan ang itong mga ginikanan itong ipagawas nga ang inyong mga PWD kamo gawas at mo sa inyong pinakaduol nga social welfare office sa barangay para ma-recognize, ma-appeal mo, ma-membro mo sa persons with disability kay daghan kayong mga pribilehiyo na karon sa ato ang mga persons with disability.
Facilities mga PWD nga dili mauntangan ng paglaom, nga bisan tinulog namin mga disability, dili kini mahimong babag para makabot mo ang gusto mo makabot. Apan kinahanglan pud lihok lang sad lumanan sa pagampo kay wala may mahimo hindi pud ang lihok so wala may imposible kung magampo lang pud sa Ginoo then dili-ligid ang ngayon ikaw ang disability mo kay adunay plano ang Ginoo namo adunay plano ang Ginoo sa kasanagan ng kawag din
parehas na ako. Pagin magpakawas paglaong niya. Ampo. Sunday Tino, pamilya. Kuha lang ikakusog sa pamilya ba. Mga una nga. Kapoy na. Naon mo na. Lapay pamilya dito. Ani na. Mga lipay, mga pa na lang makakita yung buwi. Istorya pa. Hindi lang ipagpagawas paglaong kayo. Plano, inis Ginoo pagbuo na line sentrum mo na rason na Ginoo biya kita na ko kaya ibawas plano na to batag sa tagsarat hindi lang yung sulit watson lang ito ang sagi yung desisyon.
Thank you so much, Sir Melvin, for that very inspirational message. Hope is indeed never lost. What do you think about it, Golda?
I actually agree. Because where there is hope, there is faith. And where there is faith, miracles can happen.
That's true. That's truly inspirational indeed.
I also have one fact on PWDs.
Sure. What is it?
Did you know that the WHO, or the World Bank report, actually provides the best scientific evidence to improve the well-being of our PWDs?
Nice. I also have one fact. Did you know that over 170 countries signed a treaty called the Convention of the Rights for Persons with Disabilities? This protects and promotes the rights of all PWDs.
So with that fact, do we have a way to help our PWDs?
We do. There's a lot actually. But first, how do we help Sir Melvin?
I think I know, Carla.
Go ahead, Golda.
Here it goes. We are currently on the second wave of Sulbong Paknaan, and we're going to discuss the 3 different approaches of the PFC matrix to get to know our patient in a holistic manner. So we have here the PFC matrix, which is a patient-centered, family-focused, and community-oriented approach to care for individual patients and their families. It is a perspective that the patient's concern cannot be taken in isolation, but rather both biomedical and psychosocial aspects of the patient's predicament may affect the impact of the disease and should be considered when planning delivery of care. We have 4 components, which include data gathering, analysis, assessment, and management for each approach as shown in the table.
Let's start with the patient-centered approach, which utilizes the interplay between biomedical and social factors in order to implement management that is tailor-fitted to the needs of the patient. For the data gathering, the biomedical history and physical findings show that our patient is a 38-year-old male with no known comorbidities. However, he has been paraplegic for 6 years secondary to motor vehicular accident and has recurrent decubitus pressure ulcers. He also has a history of autonomic dysreflexia, generalized atrophy, loss of sexual function, neurogenic bladder and bowel, and knee contractures. He is also a current smoker and is enrolled in the teletherapy program of the PTOT department of Valles College. The psychosocial issues of the patient include, first, being dependent on the family members for his activities of daily living, limited activities for leisure, being passively motivated to improve his condition and functionality, and feeling socially isolated. We have here the International Classification of Functioning, Disability, and Health, otherwise known as the ICF, which is provided by the World Health Organization as a standard framework and biopsychosocial model for the description of health and health-related states. This figure shows a WHO ICF model of disability diagram for our index patient. This presents the complex interrelationships between the health condition and contextual factors to his current functionality. For the analysis, the biomedical history and physical findings reveal no significant improvement in functionality over 6 years. Patient is receptive to regular PTOT sessions and participates in his wound care for ulcers daily. Psychosocial issues include his perception of his physical and mental health as good, and his perception of poor health services and healthcare worker support. The patient is also resigned with his condition and has difficulty in his community life. For the assessment, patient has spinal cord injury, anatomic level T3, motor level T3, sensory level T3, neurologic level T3, secondary to T3 to T4, anterior listhesis, status post spinal instrumentation at T3 to T7, secondary to motor vehicular accident. He also has a neurogenic bladder and bowel, pressure ulcers grade 4, right sacral area, and grade 2 left sacral area, and autonomic dysreflexia. These are the managements given for our patient. He was given education on the importance of physical therapy rehabilitation to motivate him to continue with his PTOT sessions. He was also advised to continue wound care for ulcers and on nutritional requirements for his condition. He was also encouraged on proper bed positioning. He was provided an egg crate bed foam to decrease the risk of forming additional pressure ulcers, and was provided a 3-pound dumbbell for his teletherapy sessions for upper extremity muscle strengthening, as well as equipment for wood carving as a form of mental health care, practice of his fine motor skills, and as a possible source of income.
Proceeding on to the next, we have the family-focused approach that utilizes family assessment tools to generate assumptions on how the family dynamics affect the management of the patient. For the data gathering, the patient lives with his mother and son, and the patient's primary caregiver is his mother. Their family structure is a unilaterally extended family. APGAR 1 shows the family is highly functional, and APGAR 2 reveals the patient gets along well with members of the household. The family is on the adjustment to outcome of the family illness trajectory, and the family map shows functional relationships with clear boundaries among family members. We have the family genogram that shows that the family has a heredofamilial disease of hypertension and a structure of unilaterally extended family. For the family map, The family has a functional relationship with clear boundaries with each other. For APGAR 1, the members of the household scored 10 and generally viewed the family as highly functional. For APGAR 2, the index patient gets along well with the other members of the household. For the analysis, using the APGAR and the family map, the family has close family relationships, and there is a high level of support and care for the index patient. Based on the family illness trajectory, the family has adapted to changes in the roles in the household. The index patient is dependent on his family for ambulation and self-care needs, and there is a poor perception and understanding of the index patient's condition by the family members. Also, they are financially dependent on the patient's wife, and they are unable to budget their expenses for years, thus the family is constantly in debt. For the assessment, the family has a history of hypertension on the maternal and paternal side, and the family is in pathologic equilibrium. We have here the Smilkstein cycle of family function that analyzes the impact of a stressful life event on the family, focusing on the members' responses, including their use of resources and coping mechanisms. This tool assessed our patient's family to be in pathologic equilibrium due to resignation about the constant cycle of deaths and having no definite plan on increasing their family income as pathologic coping mechanisms. For the management, the family would benefit from family education and proper care for paraplegics, and the family was advised to continue good communication and support among their members. The patient's mother was also advised for a checkup regarding her elevated blood pressure and also was advised to monitor their monthly family expenses.
Lastly, we have the community-oriented approach, which utilizes the social determinants of health and health systems to understand how external factors support or hinder provision of care. For the data gathering, the patient is able to use intrafamilial and extrafamilial resources. We have here the SCREAM analysis, which shows culture and religious aspects of the family to be resources, while social, education, economic, and medical aspects as both resources and pathologies. The household has only one functioning smartphone for teletherapy of the patient and for online classes of the patient's son. There is an existing support group in the locality, but the index patient is not part of any PWD support group. The neighborhood terrain is also not wheelchair friendly. There are no home modifications despite recommendation from the PTOTs. The house is far from accessible roads. There are no available transportation services, and there is restricted participation in employment. We also have here the Family Eco Map, which shows that the patient's mother is a PhilHealth member, able to use free PTOT services from the CIM-CMSS, able to receive cash assistance from DSWD, and has a means of communication with healthcare providers. For the analysis, there are challenges in accessing health resources, unable to find employment opportunities, presence of environmental barriers, and difficulty in community life. For the assessment, there is access to teletherapy amidst the COVID-19 pandemic. There is underutilization of services from support groups and foundations for PWDs, and there is lack of awareness of the services of the government for PWDs. And finally, for the management, there is a need to spread information of availability of teletherapy services of the Velis College through CIM-CMSS, to educate on the privileges given to the PWDs through their different policies and DOH programs, linkage of the patient to support groups for PWDs, and provide a smartphone for the family to use to increase healthcare accessibility.
This matrix aids family physicians in managing the patient holistically by identifying patient needs, enabling a family support system, and helping the family course through various community resources. This leads to the optimal health of the patient, a better family dynamics, and a more accommodating community and health system.
I really want to live in a world where disability is not the exception but the norm. I want to live in a world where a 15-year-old girl sitting in her bedroom watching Buffy the Vampire Slayer isn't referred to as achieving anything because she's doing it sitting down. I want to live in a world where we don't have such low expectations of disabled people that we are congratulated for getting out of bed and remembering our own names in the morning. I want to live in a world where we value genuine achievement for disabled people. And I want to live in a world where a kid in year 11 in a Melbourne high school is not one bit surprised that his new teacher is a wheelchair user. Disability doesn't make you exceptional, but questioning what you think you know about it does.
See, this world is amazing and awesome. And no matter who or where you are, you can always find the influence of disabled people all over this world. So from today onward, let's say we're not weak, but we are strong. We are disabled, but we are unbreakable.